Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. We're excited to welcome Karson Carpenter, President of Compliance Training Partners, as our speaker tonight, as he will review how to practice safely and profitably amid shifting COVID-19 regulations. Before we get started, we got a couple of reminders for you. At any point during tonight's webinar, we do encourage your participation. Please type any questions you might have into the Q&A section of your control panel, and we'll answer them live at the end of the webinar. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. And this webinar is sponsored by Henry Schein's Dental Business Institute, as well as Compliance Training Partners. Karson, thanks for being with us tonight. We're looking forward to it.
You're welcome, Adam, and thanks for having me. Thank you to Henry Schein for inviting me to do this. Just to give all the attendees a little background, one of the reasons that I really like doing these is, like you, I'm a practicing dentist. I know we probably have some dental team members on there too, but like you, I'm a dental professional, seeing patients. I know what it's like out there. We've had a rough go for the last year during COVID. We're starting to come back, and I realize that things are getting better. We're still not out of the woods, and I want to keep all of my colleagues in dentistry out of trouble. We have a sterling record. There's not been one documented case of COVID coming out of a dental office. And part of it is, we followed this phased approach that the government has. Our professional associations, guidance from the CDC, guidance from OSHA. And really what federal guidance has said is that each profession needs to develop and implement appropriate policies based on our industry's best practices. So we're talking about the things we've all been doing: social distancing, sanitation, disinfection, and it's worked. I mean, it's been an incredible record that we've had. And when you stop and think about it, I mean, of all professions, here we are right on top of patients, dealing with aerosols, dealing with patients very close up. I mean, there's no social distancing. There's no 6 foot away from your patient. And yet we don't have any cases of COVID coming out of the office. And that's a record you should all be proud of, but I want to keep it that way. So what I want to do, I want to outline current best practices that exist today. And I want you to keep in mind that, and this is almost every community in the United States, this is a CDC definition: minimal to moderate or substantial transmission. I realize that takes in a wide breadth of things, but we are able to do elective dental care. We've all been doing that on patients that we've screened. We don't suspect that they have COVID-19, and we can treat them. We can do all the procedures we want to, as long as we're doing it in the way I'm going to outline in this presentation. And again, as I say, we can't let our guard down. Don't forget, only 10% of the population, and actually yesterday the number was 9.2. 9.2% of the population has been immunized. So 90% of the people we're seeing haven't been immunized. Probably most of us have been. That gives us a good degree of safety and comfort. And of course, remember to regularly consult your state and local health departments to see just what's going on in your area regarding community spread. So a lot of people know our company because of its reputation with OSHA, with infection control training, with HIPAA training. But what OSHA's role is in all this is as it's always been. OSHA, I always say, really, people think I'm saying in jest, but it's actually true. OSHA really doesn't care about our patients. They really don't. They only care about employees. That's OSHA's job, is to make the workplace safe for all employees. Now, they've announced they're going to conduct more on-site and remote inspections due to COVID-19 concerns. They've also announced COVID-19 is a reportable illness. In other words, if you contract COVID from your job in a dental office, and it requires more than hospitalization or just days off work, it needs to be reported. It's what they call a reportable. Now, Compliance Training Partners, over the last year, we've been involved with a number of COVID-related inspections that started because of concerns over how employees were being protected in the practice, concerns about infection control, which then leads to other things. Once they're in there, they're not just going to look at COVID, they're going to look at what are you doing regarding hazard communication? And do you have an eye wash? And do you have a written program? So COVID has led to a number of inspections we've dealt with. Also, what's really interesting, and this has just happened in the last week, OSHA is really a little bit in the doghouse. And they're in the doghouse of the Inspector General, the IG. So the IG has basically said, look, you haven't done as many inspections as we should do, and you haven't really been out there enforcing things as harshly as you should over the last year, and we want to change that. So I just want you to know that they are under intense scrutiny right now to take some even more action. So I want all my colleagues to be prepared. I want you to be able to stay out of trouble. And some of the things we need to do, we need to follow OSHA regulations, CDC guidelines, like we always have. That's really nothing new. If there's any one good thing that's come out of COVID, it's that it's caused us all to up our safety and infection control game. And I think a lot of these things are going to stick with us long term. Of course, many of the existing OSHA regulations, the things we've been training on for years, they're going to help protect your dental team from COVID-19. But then again, we also have specific guidelines regarding COVID that we need to follow. And I'm going to go over those a little bit today as well. It's interesting. Sometimes I like to take questions along the way, and we have a number of people from out of the country on the call, which is great. I'm glad to see of your interest in safety, because things I'm going to talk about really kind of are practical things that should be done all over the place. And what Doris had said here says, although we don't have compliance enforcement in my country like the US, we've got practices that are not using extraoral evacuation machines because they're noisy. What do I think about that? Not really necessary in all cases. And I'm going to go over that. I'm going to go over when you need to have something like that and when you don't. So what I'm going to say, though, is continue to follow the guidelines we always have. Continue to follow the specific COVID guidelines we're going to go over. And of course, remember the annual OSHA training is key. Something OSHA is always looking for when they come in. And the reason that the requirement is annually, it's just one of those things. If you don't go over it once a year, you tend to forget it. And safety is a high priority in a dental office. So a few basics. I don't go into these in too much detail because we've been living with this for a year. But still, a quick review. We all know this is caused by the virus SARS-CoV-2, and it's primarily spread from respiratory droplets. The good news is there is not much going on in the way of spread transmission by touching contaminated surfaces. I mean, I still think it's really important that we're wiping the doorknobs and wiping the handles and washing our hands. But the good news is, if there is good news here, it's mostly spread by respiratory droplets. And although this virus has been shown to persist in aerosols for hours and on some surfaces for days, that doesn't seem to be the main way of transmission. Although, again, you can register some levels in aerosols, it's these larger droplets that are the problem, not so much the very fine aerosols that are causing transmission of this disease. People often ask me, is it considered a bloodborne disease? And COVID is not really considered a bloodborne disease because it's spread again through respiratory secretions. But what OSHA says, and it makes perfect sense, is that the bloodborne standard offers a great frame of reference to protect you. In other words, follow all the things the bloodborne standard says, and it's said for years, and you're going to provide a great deal of protection for yourself and your team against COVID at the same time. So bloodborne standard is not out the window. It's still very important. I think it's always good to review signs and symptoms because, again, we don't want to take this stuff lightly. We've been doing it for so long, it's easy to just say, I guess we're back to normal, but we're not. We're not. And Two of the key ones seem to be loss of taste or smell. Everybody I personally know who's had COVID has lost their taste, lost their smell. But it's also shortness of breath, persistent pain, pressure in the chest, fever, headache, cough, chills, shaking with chills, muscle pain. And of course, anybody who has signs or symptoms like these, they need to seek medical attention to get a differential diagnosis. Is it COVID? Is it the flu? Is it something else? And of course, COVID can be spread by people who don't show symptoms, which is a scary thing about that disease. Especially young people seem to have the ability to spread it and asymptomatic. Who's at highest risk? Like so many respiratory diseases, people over the age of 65, but even more than just assigning an arbitrary age to it, it's people with comorbidities, pre-existing medical conditions like diabetes and high blood pressure, and maybe they're on immunosuppressant therapy, being treated for cancer. Those are the things that put you at higher risk. And when you look at just who died over the last year, it tends to be, and obviously there's exceptions, but it tends to be mostly that group of people. So where are we at today? Emergency rules and guidelines have been enacted. They're still in force. Nothing's changed. I just want you to, as I really keep the pedal to the metal, keep doing the things we're doing, because this pandemic is still here. Again, I know there's great reports on the news, but again, stop and think about it. Only 10% of people have been immunized. Again, no reported clusters out of dental facilities. I'm really proud of that, and I want to keep it that way, because what we don't need our patients to hear is a story on CNN about a cluster of COVID coming out of a dental office. I mean, we don't need that. We need people to come into our offices. It's a safe place to be. Now, of course, elective procedures can be done as long as people have the appropriate PPE, which we're going to go over tonight. And just remember, if PPE ever does become limited, I know the supply chain is getting better, but if it becomes limited, that's when we have to prioritize treatment, because we can't be doing it without proper PPE. So some things we want to keep doing, we don't want to change this, is we want to update patient medical histories, via computer, via telephone, before the visit. We want to use teledentistry where possible for non-emergency consultations. And I realize dentistry is such a hands-on thing. There's not the room for teledentistry that there is for telemedicine. I understand that. But still, there are some times when you can answer questions over the phone and not have somebody come in. And some of the things you want to ask, of course, is, have you been around anybody with confirmed or suspected cases of COVID-19? And of course, then you want to go through those signs and symptoms that we talked about on a couple slides ago. Do you have any of those signs or symptoms? So let them know, too, that if they do have any of those signs and symptoms, they've been around somebody with COVID-19, we don't really want them to come into the office yet till we're sure they're out of the woods. Advise them, too, that when they come in, it's going to be a little different. There's going to be a special screening performed, especially, it's been about a year since this thing really got going, and we're starting to see some patients that were quite scared and are coming in now. And this whole taking your temperature and meeting them at the door is very intimidating to them. So prepare them. And I say here, see the COVID-19 pandemic period questionnaire at compliancetrainingpartners.com. And one of the things I'm going to show you here, I'm just going to, because you'll see me a number of times refer to compliancetrainingpartners.com. The reason I do that is there's a lot of things on here that we just simply don't have time to go over. And on the home page, you'll see important COVID-19 information, learn more. I'm going to be referring to this learn more button several times tonight. When you go to this, okay, you're going to find a number of different helpful things from the CDC, things from OSHA, N95 respirator information, which you'll hear me talk about, how to do a fit test. We actually have a written respiratory protection plan for you that you can just download. These things are all free of charge, just things to help you. Patient questionnaires. So you're going to see me talk about this a lot. When I get to the training section, you're going to hear me say, we don't really have time tonight to train on proper donning and doffing of PPE, but we have here the CDC guidelines, the CDC videos on this. We have an OSHA checklist, so you can go through your office and see where you're in compliance, where you're not. And of course, whatever the latest from OSHA and CDC is, we have it on there. So I think you'll find this really helpful. So enough about that, but I will be referring to that from time to time. Now, to prevent transmission, any patients who answered yes to these screening questions, again, let them know, I'm really sorry, but we need to have you contact your physician or the public health department. We need to reschedule your appointment because we can't treat people who may have COVID unless we have airborne precautions. And we just don't have those. When we talk about airborne precautions, we're talking about negative pressure isolation rooms that have HEPA filtration of the air, UV irradiation of the air. We just don't have that in dentistry. So work together, though, with a medical provider to find such a facility. If somebody's really got an emergency, they're in pain. You can't treat them just pharmacologically. Somebody needs to see them. We need to find a place for them to go, probably a hospital-based facility, dental facility, where they do have airborne precautions. And again, remember, it is our duty to report COVID-19 cases to the public health department. No HIPAA problem there. So what if you do all these screening things? You try to do all the right things, but all of a sudden somebody gets into your office who's confirmed to have COVID-19 or they're symptomatic. We've had it happen 2 times in the last year. All of a sudden there they are. So what do? Make sure they have a face mask. If they're in your operatory, they've taken the face mask off, get a face mask right on them, send them home if they're not acutely sick. If they are really sick, and that's unlikely that's going to happen in your facility, but you need to refer them to a medical facility, probably the local hospital. And again, if dental treatment's urgently needed, we need to refer them. We can't treat them there. At Compliance Training Partners, we get a variety of questions on this, and our technical team often gets questions like regarding N95s. We've heard that if we wear an N95, we can treat people that may have COVID, and that's just not the case. Now, what about patients, because we're starting to see them now, who've had COVID-19 or may have had COVID-19? Here's what and by the way, this is all on that website that I showed you, so the details are there. Patients diagnosed with COVID-19, they're not severely immunocompromised. Their illness was mild to moderate. In other words, they weren't on a ventilator. They weren't hospitalized. They basically stayed home. They felt terrible. They got better. So people like that, they can discontinue home isolation and come in to see you if at least 10 days have passed since their symptoms first started, and at least 24 hours have passed since they've had no fever, and they're not taking Tylenol. In other words, no fever-reducing medications. So 10 days since symptoms onset, 24 hours since a fever. And other symptoms that they had, whether it was cough, shortness of breath, chest pain, those things have all improved. Now, if the patient had critical illness, in other words, they were hospitalized, maybe they were on a vent, they're severely immunocompromised. Now there's more stringent requirements. You can find those under patients who've had or may have had COVID-19 at compliancetrainingpartners.com. You're going to find the guidelines there from the CDC. Now, this is a recently added slide for me because so many offices have questions about employees returning to work who had COVID-19. Again, they didn't catch it at the dental office. They caught it from somewhere else. But what do? It's really the same thing. If you've got an employee, you can follow the same guidelines as for patients. In other words, 10 days since they've had symptoms, 24 hours with no fever, and they're not taking Tylenol. Other symptoms have improved. Those people can come back to work. Unless, again, they were one of the outliers who had a critical illness, they were severely immunocompromised, Then there's more severe or more stringent requirements. Again, you'll see those under returning to work after having COVID-19 at our website. And by the way, one thing that I think is very good, unlike a lot of webinars where, I always say the speaker kind of disappears into the ether, you have full access to us at Compliance Training Partners. Just go to the website. There's an 800 number. We have some really highly trained people who are actually certified OSHA trainers who can answer your questions. So if you have a question that we don't get to tonight or something I didn't go over, don't feel this is the end of the road. You can contact our team and get some answers. Pre-procedural mouth rinses, great idea. It almost doesn't matter which one you use. There's no long-term data on it. Could be one of the essential oils. It could be Paradex. It could be one that you make up yourself with 3% hydrogen peroxide. Remember to have anybody who accompanies the patient wait in their car. If somebody does have to come in, maybe it's an elderly patient or a pedo patient, they need to be screened for COVID-19. They need to wear a mask or cloth face covering as well, just like the patient. Our waiting room, which used to be really beautiful, I thought, is pretty Spartan. No magazines, no toys, no prizes. Yours should be the same way for right now. The remote control's gone. All of that's gone. Remember, too, make sure you do a short exit interview when the patient leaves, no matter what they've been in for, hygiene, restorative. Mrs. Smith, if you develop any symptoms of COVID-19 or you're diagnosed with it within the next 48 hours, please call our office, because we need to know if somebody was in the office and we may have been exposed. The good news, and again, if you go to this, our website, CDC's healthcare personnel with potential exposure guidance, you'll find out the good news is you don't have to close your office. We get people calling Compliance Training Partners all the time. Heard I have to close my office for 2 weeks. You don't have to do that. But if you're using the proper PPE, as I assume we're going to, you don't have to close the office. You simply have to self-monitor. Someone asked here too, if the risk is for the 65 plus age bracket, what's your opinion about dentists, 65 years old in practice? Is it safe for this group of dentists to practice? It is, and we're going to go into that near the end. We're actually going to have a Q&A at the end, but I do think it is with some restrictions, but again, questions you're asked, please keep asking questions along the way. We'll tally them up. We'll get to them at the end for sure. So throughout the day, disinfect your high-touch surfaces in the waiting room. Place signs in strategic places regarding hand hygiene, respiratory hygiene, cough etiquette. I'll show you a sign like that in a minute. It's a Henry Schein product. All staff members, you should still be self-monitoring for symptoms daily. Don't let your guard down. I've talked to a couple offices lately that said, look, haven't had people come in who they were concerned about anymore. They're not taking temperatures. Keep taking temperatures. Record them. We need to do that not only because it's the right thing to do, but to eliminate liability for our business. Should any staff member have a fever or symptoms, they need to be sent home. Make sure that treatment room is set up to the best of your ability so that you don't have to open cabinets or drawers. I realize occasionally you do. Try to have everything preset. We're doing that better than ever now, and I think we're going to stick with that long term. Remove all non-covered items from the operatory wherever you can. It's so important to not have stuff sitting there that's being contaminated with droplets. Cover your keyboards with clear protective barriers. Change those between patients. Even if you didn't use the keyboard for that particular patient, change them between patients. For respiratory hygiene and cough etiquette, this is the sign that I mentioned. I used to say, this was back pre-COVID, just post it at your entrance, but now I say put it at several places throughout your facility. Make sure that you have no-touch receptacles, the kind of can you step on and don't have to touch in the waiting room and throughout the office. Provide tissue, provide alcohol hand rub in the waiting room and throughout your office. Paper towels, C-folds to wipe your hands. And insist that everybody come to your office wearing either a mask or a cloth face covering. Now, I used to go into this in some detail. I really don't now, but I do have what are considered emergencies and urgencies at our website under COVID-19 emergency care. Should you get in a situation, it could just be temporary, where you can't get the PPE you need. And if you can't, we need to start prioritizing again. Now, hand hygiene recommendations, really, they've always been important, but especially now, artificial nails, not recommended. Short, smooth fingernails are better for cleaning and disinfection. Jewelry, it's okay, but if it's going to pierce a glove, if it's large, if it's sharp, it shouldn't be worn in the dental office. Regarding personal protective equipment, in dentistry, it's designed to protect our skin, our mucous membranes like our eyes and our nose and our mouth, so that we're not getting blood or other potentially infectious materials like saliva and droplets. So we're not getting that chance of transmission. So when I talk about PPE here in COVID and even without COVID, we're talking about masks and gloves and respirators, face shields, protective clothing, and we'll go into this in a little bit more detail in a minute. Now, the PPE that we've always used in the OSHA's Bloodborne standard, that's designed to protect employees. Now, what's interesting is the very same protocols, in other words, mask, gloves, glasses, respirator, all those things that protect us as workers, under CDC, those same things protect the patient. There's kind of a duplicity there. The gloves that protect us protect the patient. The respirator that protects us protects the patient. And regarding the face mask, of course, its real job is to protect the mouth and the respiratory system, but it's also to protect the patient from us. Okay, that's probably one of the main uses of a mask. It needs to be replaced between patients, or if it happens to be visibly contaminated, which rarely happens in dentistry. So basically, we're talking about between patients. It should have a high BFE, a bacterial filtration efficiency rating, and the good quality mask you're going to buy from Henry Schein, they're going to have a rating on them. And we recommend that a high quality mask is rated at least a 2 by ASTM, American Society for Testing Materials. So what do these different levels mean? ASTM International, they establish performance levels. In other words, they do the testing on these masks. And they have a number of different criteria, some things I don't even mention here, like fire resistance, et cetera. But the main thing that affects us is bacterial filtration efficiency and fluid resistance. Now, a level 1 has 95% filtration of 3 micron or larger aerosols, but it has low fluid resistance. Now, the level 2 and level 3, they filter out 98% of bacteria containing aerosols. And that's why you'll find them to be just a little harder to breathe through, just a little denser. The only difference between 2 and 3 is 2 has moderate fluid resistance, 3 has high fluid resistance. I'm really a fan of using at least a level 2 in dentistry. Now, mask and cloth face coverings are something we need to talk about because people want to know when can they wear a cloth face covering. Now, a mask or a cloth face covering, in other words, a surgical mask, so level 1, 2, or 3, or a face covering needs to be worn at all times when you're in the office, other than when you're eating lunch. The business staff also needs to wear one at all time. It could be a cloth face covering or a face mask. Dentists, dental assistants, hygienists, the whole dental team, including business office people, you can wear cloth face coverings if you're not involved in direct patient care. You need to switch to a surgical face mask or a respirator if you're providing patient care. So I think that the cloth face coverings, to me, one of the best purposes for them is to save expensive and hard to find, sometimes surgical masks. So to preserve these masks, cloth face coverings can be utilized, but again, they need to be changed if they become soiled or damp or hard to breathe through. They need to be laundered daily. And whenever you take them off, you need to wash your hands. They can only be used if you're not providing patient care. This is a way to preserve surgical face masks. And of course, this leads to the questions, do offices need N95 masks? Now, N95 masks, they're really considered respirators by OSHA. Now, here's the difference. And you'll see down here in the last bullet point, we have respirators versus surgical masks from CDC at our website. But here's the basic difference. A respirator is designed to protect you and I, okay, the wearer. A surgical mask it's mainly designed to protect our patients. The difference is a respirator may not have a better filtration system than a mask. The material may be very similar, but it has a very tight seal around the face. So a respirator protects us and the patient. A mask tends to protect more of the patient than us. Now, if you're going to use an N95 mask and it's considered a respirator, you need to have a written respiratory protection plan. Again, that's available free of charge. Download it from our website. You need to have fit testing. You could do it at a local occupational medicine clinic, or I have the link to the 3M service that will do it online. It's on our website. And they'll do that medical evaluation. Now, the fit testing, that's a hands-on thing. The fit testing needs to be done by a local, it could be usually an occupational and safety and health company. Typically, what we recommend is you call a occupational medicine clinic. They can do it, or you can do what we did. We bought the fit test kit from 3M, did our own fit testing. So again, respiratory protection plan on our website, medical evaluation link on our website, fit testing, we show you how to do it and give you the information where to get it. Now, when do you want to use an N95 mask? Well, during this COVID-19 pandemic period, which I think is probably going to go on probably to the end of the summer, if you're doing an aerosol generating procedure, you've screened the patient, they're not suspected of having COVID-19, but you're doing an aerosol generating procedure, you need to be using an N95 or a KN95. KN95 is just the Chinese equivalent of an N95. It's just that make sure that is a KN95 on the approved list. And you can find that information out from Henry Schein. You can go to what's called the NIOSH, N-I-O-S-H, NIOSH website and see if your KN95 is on the approved list. So what does this mean? If you're operating a high speed, a low speed, an ultrasonic scaler, or the air-water syringe, you should be using a respirator because these things generate aerosols. So if you enter an operatory, there's a patient, they've been screened, they don't appear to have COVID-19, you can wear a surgical mask with eye protection. Your eye protection could be goggles or safety glasses with side shields, or it could be a full face shield. But if you're performing an aerosol generating procedure on that screened patient, now you need to go to an N95 or equivalent, like a KN95. And you need to replace that surgical mask with a KN95 or an N95. And you need to, instead of wearing just safety glasses, you need to wear a face shield. In our case, we're wearing basically safety glasses because, like many of you, I wear loops with side shields. Those are safety glasses. And then we wear a face shield over it. But the key thing is going to the face shield when you're doing aerosol generating procedures. Yeah, great thing about a face shield, not only does it provide great protection, but it does protect that N95 from getting wet. So remember, when it comes to clothing, leave all your protective clothing in the office for laundering or pickup by a laundry service. That hasn't really changed. We've always recommended to be in compliance with OSHA. You leave at least a long sleeve, high necked gown or something in the office for laundering. We really prefer that you leave everything, including the pants, in the office. You don't have to. In our office, we choose to leave a long sleeve scrub top, the scrub bottom, even our shoes. We leave everything in the office, and we have a laundry service take care of the top and the bottom. But at a minimum, you need to be leaving something long sleeve, high neck, the top in the office for laundering. During this pandemic period, this clothing should be changed between patients. That's why many times to do this, you either need to buy a lot of washable gowns, which we have, and combine it with disposable gowns. So we use both to be able to keep up with this. Don't wear your protective clothing in the eating area. It's really important to take it off before you go in and eat your sandwich. And any of your clothing that you're leaving in the office to be laundered, put it in a fluid-resistant bag with a biohazard symbol on. Again, that's a Henry Schein product, but you should have something like that. As I mentioned, disposable gowns, they're a great option. Now, on the website, I think when I first went on, I showed you there was that link to the CDC's donning and doffing of PPE. So it's always been important to know how to put it on and take it off. But even more so during COVID. Again, this is one of those things, maybe it's one good thing about COVID. I'm trying hard to find anything good, but it's going to teach us that there are certain specific ways to put on PPE and to take it off. There's a certain order to do it and a certain technique. It's very easy. So make sure, because this is part of the training requirement, that you show your staff, maybe next week you take 15 minutes and show them these 2 videos on proper technique for donning and doffing PPE. Work practice controls, these are behaviors or things that we do that will make the office safer. A couple important ones for COVID. Remember to encourage sick employees to stay home. I mean, I know in the past, I can remember just dragging myself into the office years ago. You know, my sinuses are going crazy under my mask. I feel terrible. I just don't do that anymore. I know it's difficult for staffing sometimes, but we really need to have non-punitive sick leave policies. So if people really think they're sick, they're not going to come in and bring it to the office, because we sure don't need to have them give it to us or to our patients and have to close down an office. Minimize contact between employees in the office. In other words, social distancing within the office. For example, our lunchroom, which used to 6-8 people eat at a time, now it's just 2 at a time. They have barriers between them. Work at home arrangements, you know, not easy to do in dentistry. We're able to have our insurance person work from at home quite a bit. We're also able to have some of our full staff meetings by using Zoom and having people at home. So where possible is the word. Other important work practice controls, try to minimize the use of saliva ejectors. People put their lips around them. Backflow can be a source of cross-contamination into the dental unit. Minimize the use of the air-water syringe. That creates aerosols for sure. Maximize the use of high-volume evacuation. In other words, four-handed dentistry, or any devices like an isolite that connect to it. Studies have shown that good use of high-volume evacuation can cut aerosols by as much as 90%, which is incredible. I know we can't use a rubber dam all the time, but it can really, it can dramatically decrease our exposure to aerosols. I say try to minimize aerosol generating procedures. Obviously, there's things that we do that there's no other way to do it. But one of the things that we've done, we continue to do, many of our offices, clients, when I'm speaking of clients, have embraced, is trying to do the aerosol-free hygiene visit. In other words, we're not using the ultrasonic scaler and we're not using the rotary polisher during this pandemic period. I will tell you that probably in almost a year's time, I think it's about 9 months' time since we opened back up, we've had 2 patients complain about it. That's it. When you explain to them we're going to be able to get back to normal later this year, we're trying to not generate aerosols to protect you, to protect us. What are they doing? They're doing hand scalings. Their fingers are getting stronger, like we used to do in dental school. They're polishing with, in this case, just using the Profi paste and a gauze on their finger. You know, I'm not saying it has to be that way forever, but think about what will work for you. One of the main reasons we did that is because those N95s, especially at the beginning, were so precious, we couldn't get enough of them. If all 3 of our hygienists had to use N95, we were going to run out of them. So instead, by having an aerosol-free hygiene visit, we could preserve the N95s for the restorative procedures where we needed them. So in other words, our hygienists wore just a good level 1 or level 2 surgical mask. Some engineering controls. A lot of times people are looking for really expensive solutions, but you know, it doesn't necessarily have to be an expensive solution. For example, these, I call them the elephant snout machines, the big, noisy, high volume devices that go over the patient and suck out aerosols. Well, you know what? If you're doing really good four-handed dentistry, really good suction, you may not need it, especially if you have, like we happen to have, an opening window in the operatory. We placed a small fan in it. We're talking about, you know, $15 fan, not expensive, and point it to the outside. So the air, any aerosols created in that operatory are being directed to the outside, not through the office. We've turned the fan to our heating and cooling system to on during working hours. So now you hear it blowing all day, even when the furnace isn't on or the air conditioner isn't on. So it's exchanging that air 8-9 times an hour. Again, these local exhaust devices, HEPA filtration devices, a great idea. They can be expensive, but stop and think about, because I'm all about protecting us and protecting our patients, but I'm also about we've got to be profitable here. And sometimes it's hard to spend thousands of dollars on all of these items that we may not even have to use in another year. If you're at our office with 12 operatories and opening windows, we do real well with fans. Maybe if I was at a small 2-operatory office in a building in Midtown Manhattan with no opening windows, I may have a couple of those HEPA air filtration devices. But instead, we've been able to find inexpensive ways. So using directional airflow, and that's not my wording, that's wording from OSHA. Use directional airflow, such as from fans, to direct air from the staff work areas, like the operatories, towards patient care areas, not the reverse. So in other words, our fans are pointing from the operatories, maybe going down a hall from operatory to operatory, then exiting out the window, not pointed in the direction of the kitchen or the staff room or the doctor's private office or the front desk. So away from treatment areas, away from those areas, not towards staff areas. And this is what we've done, just inexpensive, simple stuff. Fans are taking this from the operatories and finally culminating in a fan pointing outside and exhausting that air. So again, some things you might think about, because I want you to stay safe, but I want you to still be able to make a living doing this. And, listen, we've got competition. We've got still, according to statistics, about 15% of patients who are scared to come in. We've got insurance companies beating us up. Wherever we can be safe and save some money, I'm all for it. And this is finally where it exits our office. Now, some engineering controls. Again, you've all got probably vent fans in your bathroom and laboratories, but you never turn them on. Turn them on. Run them all day during working hours. That will really help your air quality. Something that's been pretty inexpensive, I found, is talk to a heating and cooling expert. Instead of having to, again, spend $4,000 per operatory for a device, talk to your heating and cooling system people who may be able to either, one, put in a bigger fan, so you're a bigger blower, so you're putting more air through your facility, or two, they can put a better filter on, like a HEPA filter on your central heating and cooling, or they can put a UV irradiation device. So as it goes through your cold air return in your furnace or your air conditioner, it helps disinfect the air. If you have operatories that have partitions or walls between them, try to use those. If you only have open operatories, try to put some type of physical barriers between them, like curtains, something you can wipe down easily. In our case, our office, we have, like most of you, our operatories are divided by cabinetry. It's not a full solid wall, but it's a great barrier. Also, use these plexiglass barriers in the business office like this between staff and patients. Also, I'd pick up some and put these in your areas, your staff areas, like, for example, the kitchen where people may eat lunch. We have several of these to divide the area up. Again, these are some of the things we've used that are very inexpensive solutions. UV irradiation of the air, a much better furnace filter. We used to have one of these cheap, slender fiberglass filters. Now we have a high-level HEPA filter. Didn't cost much at all, and it covers the whole office. Some other precautions you can take: when you enter the office, staff members should perform hand hygiene right away. And they should also wash their hands before they leave the office. They should wear a cloth face covering or a surgical mask when they arrive. They should wear one when they depart. And don't let up on these things. I know you've heard these things before, maybe from me, but the reason I still have this in this presentation is I'm starting to see some people let up a little bit. I just don't want you to do that yet. So continue, for environmental surfaces, continue to follow all the things that we've taught. Basically, CDC guidelines for infection control, they're found on our website. Do all the things that you have regarding OSHA training. Clean and disinfect with an EPA-registered hospital-grade disinfectant, like we've always suggested, but make sure it's one that's effective against SARS-CoV-2. Now, the EPA has a list N, and on this list are disinfectants that are effective against SARS-CoV-2. Now, we've actually put it on our website. You can take a look and see if your product is on there. The good news is that almost all the big names, all the names that you would buy from Henry Schein, are on that list. Fortunately, SARS-CoV-2 is not particularly difficult to kill. So what is important, though, is even if you're using a good product, a great time to make sure staff is reading the label and following the manufacturer's instructions for use. In other words, if it kills in 5 minutes, but they're putting it on there for just a minute, doesn't matter how good that disinfectant is. So follow the instructions for use. One of the things that during this pandemic period, there's been concern because there weren't as many patients going through the office, and people were concerned about dental unit water quality. We've always taught this, but now more than ever, remember the CDC states your dental unit water should have less than 500 colony-forming units of bacteria per cc of water. The ADA says even less, 200. Now, if we were practicing in Europe, the number is 100. Now, you might say, how do we achieve that? Because, I mean, we all know the dental unit's ideal for growth, has small diameter tubing, biofilms form. But I can tell you that if you do some of the things we'll talk about in this presentation, if you maintain your system, you'll easily be able to achieve even European standards. It's just not a problem. Keep in mind, again, because I'm the guy I'm not trying to get you to spend money. I want you to protect your business. Major lawsuits have been filed by patients against dentists who've had high levels of bacteria in their water lines. Don't forget that the water's not perfect at its source. It can contain bacteria. Retracted oral fluids can also, even in a brand new unit, I know they have anti-retraction valves, but they're not perfect. They can become contaminated. And biofilms can harbor bacteria. They can protect them, allow them to grow, multiply inside your water lines. So some of the challenges, it's not possible to make our system sterile. It just isn't. But data shows 31% of tested water lines fail. I'd like you to make sure you're not one of those. 61% of practices have had at least one operatory that failed. And interesting, when they culture the bacteria, the primary source of bacteria is the municipal water supply. Some people say, well, I use reverse osmosis for my water. I have a distiller or a filtering system, but these have all been known to fail. What do I find works? There's a lot of different ways to do it. But first of all, I really believe you need to have self-contained water bottles. What I like about that, you can control the quality of the water. So if you have a boil water notice, you can go to the store and buy some distilled water and put it in there. That way you can maintain your water system. You can put in water line cleaners, low-level disinfectants, shock treatments. So that's why I'm a real fan of this. What works for us, what works for our clients? Shocking the system overnight quarterly. Use a water line cleaner weekly. Purge the water lines on the weekend. I love to leave water lines dry because nothing kills a biofilm like desiccation. Test your dental unit water. Maintain the log of testing so you can prove when your patient says they contracted a bacteria from your office, I want you to have actual records showing that you're testing every quarter because the EPA, OSHA, and all the major dental unit manufacturers recommend that you do that. Another simple thing, make sure to discharge your water lines for 20 seconds between patients. Just like when you go up to a drinking fountain, right? That first shot of water, let it run for 5-10 seconds. That's the shot of water that has the most bacteria. So how clean is your dental unit water? Unless you test, you don't know if it's really great or if it looks like this. And again, enough said about that, but not only is it the right thing to do ethically, but it's going to protect your business from liability. Now, staff training in this COVID period, staff needs to know when to use PPE, what PPE they need to use, how to properly put it on, take it off, how to dispose of it, how to disinfect it, the limitations of it. In other words, A cloth face covering is great, but you can't wear it in an operatory because it's not going to protect you against an aerosol. Okay, so these are things that staff need to know. Again, by the way, my PowerPoint from here is also on our website. If you'd like to show this to your staff, just feel free to open it up and show it to them at a training session. I always say patient and staff reassurance is so important. If you haven't done it, be proactive. Make sure it's on your website. Make sure you're sending letters to your patients. Let them know you're monitoring the situation. It's changing all the time. You're following OSHA guidelines, CDC guidelines, ADA safety guidelines. Make sure that your staff has the information they need to communicate with patients. That's one of the reasons why when you do training, I really suggest showing them information like this PowerPoint, even your front desk, your business office people, because many times they get ignored, but they're the people who are taking the phone calls, right? They're the ones who Mrs. Smith calls, she's tentative, she's afraid to come in, or she wants to cancel her appointment because some neighbor told her a story about people getting COVID from the dental office. So people need to know how to communicate with patients and let everybody know. I mean, we're all about safety in the dental office. As some of I call them A patients, right? We all have A patients, our best ones. As they told me, they said, we felt really safe coming in here because unlike our medical office, our chiropractor's office, or wherever else we went, you guys always wore gloves and masks and glasses. You know what you're doing. So that's a real positive thing. So the demand for our services, it continues. We're seeing our clients are getting back to COVID production levels. For those that are entrepreneurial minded, a lot of them are acquiring practices are expanding. Borrowing rates are at an all-time low. In fact, it's why I think I heard the stock market was up today. The Fed decided to not raise interest rates. So there's cheap money out there. Maybe it's a good time to grow your business. And as I said, patients trust us. They've been coming to us for a long time. And remember to tout that fact. No clusters of COVID-19 have come from a dental office in this country. Zero. Again, all staff members, everybody needs to explain this program. Make sure that everybody knows what you now know, the things that are on our website, and let patients know, communicate with patients. We need to get them all back. Now, as I'd mentioned, feel free to visit our website where we will be glad to answer any of these questions you have. Most of them you'll be able to just answer from the website. If not, certainly contact our technical services team. And with that, I would like to turn it over to Adam from Henry Schein, who is going to help moderate any questions we might have.
Excellent. Thank you. The first question we have here is, do you think all of these current restrictions will change upon herd immunity, or will they continue even though we have more people vaccinated?
I think once we achieve herd immunity, we're going to start to see things get easier. For example, I think we may start to see things happen like you don't need to wear an N95, or you don't have to change clothing between patients. But right now, don't let up. But I'm certain we're going to see these things change.
For laptops, do we need to cover the entire laptop? It's really not something we're looking to do.
I would just cover the keyboard is what I would do. And unless you have a touch screen that you're actually touching the screen, then of course I would do that. But if you're only touching the keyboard, just cover that. Certainly, though, I would take one of these disinfecting wipes, not your intermediate level disinfectant, which would be tough on a screen, but a low level disinfectant wipe, and make sure you wipe that screen at least once or twice a day.
What are your thoughts on fogging with hypochlorous acid?
I will tell you, I've never done it. I've read the literature on it. It looks very good. But here's what I'm going to tell you. Stop and think about the things we talked about in this webinar. It's not coming from touch surfaces. No cases have come from dental offices in this country. And remember, guys, I'm not the academician. I'm a hands-on, wet-figured dentist. I want to do things the right way, but I want to keep you guys out of trouble and allow you to make a living. I'm going to tell you, I just don't think you need to do it. I think it's time, it's expense you don't need. Keep doing what you're doing regarding environmental surface disinfection and do the things we talked about in this program. And I think that's all you need to do. But does hypochlorous acid work? It does. I just think it's overkill.
All right, this next one I'm not sure about, so we'll see if you know. If not, I'll have to follow up on my end. But does Henry Schein carry photocatalytic oxidation filters? And if so, do you recommend them over HEPA filters?
You know, I don't believe Henry Schein carries those. I believe the only thing that they would have would be devices that have HEPA filtration, HEPA filters in. I will tell you that, again, the literature on those is very good, but I will tell you that HEPA filters are reasonably inexpensive. They have the ability to filter out SARS-CoV-2. Again, I don't think you need to go there. You could if you wanted, but not necessary. And again, as this seminar said, I want to protect you, but we all own businesses. I want you to be able to make a profit as well.
Can you remind us again how often we should be testing our water?
I would absolutely test every operatory quarterly. The reason being, every dental unit manufacturer recommends that. OSAP recommends that. EPA recommends that. So should we ever get into trouble for not doing that, those are the standards they're going to expect us to uphold. And you can do the in-office testing, which is relatively inexpensive, easy to do.
With the aerosol-free hygiene appointments, what do people use instead of air or water syringe?
I'll tell you what we're doing. And you know, you may be hard to envision this if you're not doing it, but it's worked really well. Imagine that the patient comes in, the hygienist has them, of course, rinse with a cup of, in our case, I think they're using Listerine. It almost doesn't matter to me which mouthwash, but they're using Listerine. They're then spitting back into a cup, okay? Hygienist throws it in the sink. During the visit, any rinsing is done by them giving them a cup of water, they swish a little bit, spit back into the cup. Because again, by eliminating that air water syringe, we've eliminated the need to use all the protective gear, particularly N95s, which we just can't get that many of them. Patients seem to be fine with it.
All right, couple PPE questions here. With all of the PPE changes between patients, how many hygiene patients does your office see per hygienist? And then part two is, do we need to change lab jackets between patients?
You know, there's a couple different ways you can do it. You know, at first, when we first started doing these protocols, we went from our old hour visit for hygiene to almost about an hour and 20 minutes. But as people got more efficient at doing this, we're back to doing it in an hour. You know, it's taken some efficiencies. It's taken the use of disposable clothing to make that happen. I will tell you that there's a number of different ways you could handle the clothing issue. For example, you could, let's say you're in operatory number 1, you're doing a crown. You get called, there's a hygiene visit. If it's our office, you're going to take off that washable gown that you have, leave it in that operatory. You're going to go to hygiene and outside the hygiene room, put on disposable, do the first hygienist exam, take it off, put on the second disposable, do the second hygienist exam, done, throw it away, go back, if you're going back into room 1, putting that same gown back on. So there are a number of different ways doing it, as long as you're going into a patient with a clean gown, or obviously you can work on the same patient with the gown that you just used on them. That's not a problem.
All right, this is a great question here. Given what we've learned as a profession over the last year about aerosol distribution within the operatory, is there any reason not to continue these protocols once the pandemic is over? I think of all the times myself or staff have gotten sick in the past and wonder if some of that could have been prevented.
You know, that really is a great question. Isn't it interesting? I was never a person who got sick very much. I just wasn't. But, you know, I haven't even had a sore throat in a year. I mean, always, right? At least up here in Michigan where we live. A couple times during the winter, you at least got a little bit of a sore, scratchy throat. I haven't even had that. So I truly think that although we're going to be able to relax things, I think we're going to be a lot more careful with this. I personally think that I didn't get the things I got in the dental office because I was always careful about wearing a mask. I think I probably got them outside the office. I think this is going to change forever the way we do things to some extent. And I think we're all going to be healthier for it.
Do you recommend patients still call in from their car or from outside the office before they come in, or would it now be okay to let them walk into the reception before screening?
I still have them call for two reasons. One, that helps us kind of orchestrate the flow of patients. In other words, somebody pulls up, it's 5 to 10, say, hey, Mrs. Jones, well, why don't you just wait till 5 after 10? Because we're trying to not get multiple people in the waiting room at one time. The other thing is people, I think other people in your office see that you're doing that. They feel it's a safe place to go. Because there are people who might be nervous about coming in. They start seeing people coming into your waiting room like that. They might be the ones who stay home for the next visit. I would keep doing it for now. I think we may be able to change, I'm hoping by end of summer, but stick with it for now, please. I want to keep you out of trouble.
And I feel like I got to ask this one because I see it all the time. Are offices requiring staff members be vaccinated with the exceptions of any type of religious beliefs or legitimate medical reasons?
I'll tell you, and Adam, I'll always preface this by saying, when in doubt, consult an attorney. But I have a strong answer to this question. I just feel I've read everything about it. I've gotten advice. I've talked to legal experts. I think that what I need to do as a dentist, I need to be, as a leader in my office, I need to be such a good educator that I can give such a compelling story why the vaccine is safe, why it's effective, how it protects them, how it protects their family, that I can get them all to do it. And we've been able to. But what if you get that person who refuses to do it? I truly believe you cannot force them to do it. You certainly can't have them lose their job because of it. I will tell you that in our employee policy manual, we now have, for all new employees, they're going to read the employee policy manual. They're going to sign that getting not only the hepatitis B immunization, but the COVID and the influenza vaccine are a condition of employment here. But that's with a new employee starting afresh. If you have existing employees, give them the best education you can. And then from time to time, those that haven't done it, try to convince them, coax them to do it. Because as healthcare professionals, we believe in it strongly. We've got to convince our team to do it. You can't force them.
All right, we've got a lot of questions here and we're a little over, but I just want to get through a couple more.
Sure.
Let's see. How are you doffing and redonning a washable gown without contamination?
I will tell you that what we do is that washable gown would be placed. In my case, I place it as I take it off. I lay it with the outside over my operator's chair. And of course, as soon as before I even take it off, I've taken off my gloves, washed my hands, or used alcohol hand rub is what I typically do. And when I come back in, I feel that I'm able to do it with only touching the inside that's uncontaminated. And then, of course, again, putting on clean gloves, etc. It's not easy to do. I will tell you that on the days when we have adequate supply of disposable, that's all I use is disposable. But I found, at least in our hands, we had to buy I think we have probably about 6 or 8 washables to supplement our disposables.
I've read that UV lights create ozone, which is problematic. Is this a concern to you?
From what I've read, although in theory it can do that, it's at such a low level that I've not seen anything about there being a problem, particularly, say, when it's on the heating and cooling system where you're getting, depending on the system, typical is 6 to 8 changes of air per hour when you have that fan on. I think that's another reason for having the fan on your heating and cooling system on all the time when you're in that operatory or in that office. Just turn it on every day.
How often do you recommend we test our staff?
For COVID?
Yes.
They're speaking of COVID. I will tell you that there is no requirement or particular guidance for that from the CDC. And the problem with the COVID test is, okay, so we test yesterday. It takes 48 hours to get it back, and somebody was exposed today. So to me, there's no real, unless you want to, there's no real need to test your staff. There really isn't. If you follow the protocols we've talked about here, that would be purely optional.
And then our last question for the evening, if an employee's spouse tests positive for COVID and the employee is not showing or does not have symptoms, should the employee stay home?
You know, I would say yes. Now, I know those CDC guidelines pretty well. I'm trying to visualize them, but I believe if someone is living in close proximity in a household and that person tests positive, that other person, say their spouse, significant other, tests positive for COVID, my feeling would be that they should not come to work in that case. It would be different if they were exposed in a social distancing situation. Just like if you're exposed to someone in a dental office, a patient who has COVID-19, you don't have to shut the office down because, again, we have masks and gloves and glasses on. In a home, that's not the case. So I would, if that happened, I would say, Bill, you need to stay home. Your wife had COVID. We need to have you contact the public health department and get guidance, but I believe you're going to have to quarantine for about 10 days, 10 to 14 days.
Great. And I lied. I have one more question. Is there any guidance out there in terms of minimum time after an aerosol generated procedure before cleaning that space?
You know, I will tell you that originally the CDC had some data out that showed that we needed to wait, 15 minutes between cleanings, but between going back into that operatory. And of course, that makes it pretty tough. In fact, originally, I think they were even talking about 30 minutes, but try to run a business doing that. Now, here is the latest, everything that I've read. I read this stuff all the time. Can it be detected? Could an aerosol be detected in the air 15 minutes or 30 minutes after a visit? Yes, at some level. But the CDC has found that this is not a significant problem, that there is no need to have a downtime for that operatory. I think what's very practical, though, is the patient leaves. Typically, what we would do even before COVID, we would immediately clean the room. We would immediately wipe it. Our disinfectant now has typically 5-minute contact time, right? No problem. If you're 5-10 minutes between rooms, between patients, don't worry about that. It's of no significance according to CDC.
Great. Thank you. Well, thank you everyone for all of the questions this evening. And Karson, big thank you to you as well for your time and especially sharing this important content with us. As a thank you for attending tonight, everyone will receive this recording via email sometime in the next week. If you'd like to see upcoming Henry Schein webinars, visit henryscheindental.com/webinars for our schedule. I would like to thank you all for joining us tonight, and we look forward to seeing you back here soon. Have a great evening.
Thank you, everybody. Thank you, Adam.